Welcome to this deep dive. We're here to basically unpack a whole bunch of sources and give you the essentials on a pretty big topic.
That's right. Today it's all about mental health, defining it, categorizing the challenges, and looking at how we approach treatment.
Yeah, we've got quite a mix for you. Some YouTube stuff on therapy types and the DSM-5 classifications, chapters from the OpenStack Psychology text covering disorders and treatments.
And also a really interesting piece on therapy specifically for substance abuse, including family therapy aspects.
Exactly. Our goal here is to, weave all this together into something clear and hopefully pretty engaging for you. We want to give you a solid grasp of psychological disorders, how they're classified, and the different ways therapy can help.
Trying to connect those dots and spark some of those aha moments.
Okay, so let's jump right in. Fundamentally, what are we actually talking about when we say psychological disorder?
Well, the crash course videos offer a good starting point. They describe psychological disorders as patterns of thoughts, feelings, or behaviors that are deviant, distressful, and dysfunctional.
Deviant, distressful, dysfunctional.
Yeah.
Okay. Distressful and dysfunctional seem, well, fairly clear, right? Causing suffering, messing up daily life.
Yeah, basically.
But deviant, that one feels a bit loaded, maybe. Kind of relative.
It absolutely is. And Crash Course really stresses that. Deviance depends heavily on cultural context, on norms. What's way outside the norm in one place might be totally fine elsewhere. So that's why the definition needs the other two parts. Distress the person's own suffering, and dysfunction, like you said, it actually impairs their ability to, work, maintain relationships, that sort of thing.
Got it. So it's not just being different. It's difference plus suffering plus real-world problems.
Precisely. It's that combination.
Okay, that helps frame it. And how has our thinking about these conditions changed over time?
Oh, significantly. Crash Course touches on this, the move towards the medical model, hysterically speaking, 18th, 19th centuries, starting to think maybe these issues have physical roots, like other illnesses.
Right, moving away from just blaming spirits or morality.
Exactly, a big shift. But today, the dominant view, which both Crash Course and OpenStax highlight, is the biopsychosocial approach.
Biopsychosocial. Break that down a bit.
Sure. It means looking at the interplay of factors, biological, think genetics, brain chemistry, psychological like thought patterns, coping skills, trauma history, and social cultural things like poverty, discrimination, social support networks.
So like with depression, it wouldn't just be brain chemistry.
Right. It might involve neurotransmitters, yeah, but also maybe negative thinking patterns, maybe isolation, maybe stressful life events. It's usually a mix of all three levels influencing each other.
Okay, that makes a lot more sense, a much more holistic view. Now, when doctors or therapists try to identify these disorders, how do they categorize them? I know there are systems for this.
Yes, there are. Our Khan Academy source mentions the two big ones used worldwide, the ICD from the World Health Organization and the DSM, the Diagnostic and Statistical Manual of Mental Disorders from the American Psychiatric Association.
DSM-5 is the current one, right?
It's the one. The Khan Academy video mostly focuses on the DSM-5, which sorts disorders into about 20 main categories.
20. Wow. That's a lot. Are there ground rules for using the DSM-5, things to keep in mind?
Definitely. The Khan Academy points out a few key things. First, the mental symptoms shouldn't be, primarily caused by something else obvious, like a medication side effect, substance use, or another medical condition.
So rule out the physical stuff first.
Basically, yeah. Second, going back to our definition, the symptoms have to cause real distress or impairment in the person's life. Clinically significant distress or disability.
Right, not just a minor quirk.
Exactly. And third, just being unusual or eccentric isn't enough. If someone's behavior is odd but doesn't cause them distress and doesn't stop them functioning, that alone isn't a mental disorder according to the DSM.
That's a really important distinction. So can we maybe walk through some of those 20 major categories? Just a quick overview.
Sure thing. Let's hit the highlights from the Khan Academy overview. First up, neurodevelopmental disorders.
Okay, neurodevelopmental. Sounds like things starting early.
Exactly. These involve issues in how the nervous system develops, causing problems with functioning. Think intellectual disability, autism spectrum disorder, ADHD, things typically diagnosed in childhood or adolescence.
Got it. What's next?
Then there are neurocognitive disorders. This is different. It's about losing cognitive abilities after the brain is developed.
Ah, so a decline from a previous level.
Right. This includes things like delirium, which is often temporary, maybe due to illness or medication, and major neurocognitive disorder, which is the term for dementia, often progressive, unfortunately.
Okay, so development versus decline. What about something really common like sleep problems?
Yep, there's a category for that. Sleep-wake disorders. This covers significant distress or impairment related to sleep. Insomnia, sleep apnea, being excessively sleepy, unusual behaviors during like sleepwalking.
Makes sense. And anxiety. That feels huge.
It is. Anxiety disorders are characterized by excessive worry, fear, or avoidance. This is where you find specific phobias, generalized anxiety disorder, panic disorder.
It's interesting how something normal like anxiety becomes a disorder.
Well, it's about the degree, right? The
Yeah.
intensity, how pervasive it is, how much it interferes with life. It really highlights that mental health exists on a spectrum.
Good point. What about depression and bipolar disorder, mood issues?
Yep. Depressive disorders involve that persistent low mood, loss of interest, and importantly, a higher risk of suicide. Mood here means that longer-term emotional states.
Right, not just a bad day.
Exactly.
Yeah.
And then bipolar and related disorders also involve mood problems, but the key difference is the presence of mania or hypomania periods of abnormally elevated or irritable mood.
Mania, that sounds quite extreme.
It can be. Often involves less need for sleep, racing thoughts, rapid speech, sometimes poor judgment, risky behaviors. A very different state from depression.
Okay. And conditions like schizophrenia, where do they fit?
That's the schizophrenia spectrum and other psychotic disorders category. The hallmark here is psychosis.
Psychosis meaning?
Things like delusions, strongly held false beliefs, like believing someone is plotting against you despite evidence. Hallucinations, sensory experiences without a real stimulus, like hearing voices. Also disorganized thinking, maybe jumbled speech, and what are called negative symptoms.
Negative symptoms.
Yeah, like a flattening of emotions, lack of motivation, withdrawing socially, things being taken away from normal functioning, as opposed to the positive symptoms like hallucinations being added.
I see. Okay, those are some big ones. What else is in the DSM-5 lineup?
Well, there's trauma and stressor-related disorders. These develop after experiencing or witnessing a traumatic event. PTSD, post-traumatic stress disorder, is the classic example here.
Right, makes sense.
Then, substance-related and addictive disorders. This covers problematic use of substances, alcohol, opioids, cannabis, stimulants, caffeine even, and also behavioral addictions, like gambling disorder.
So addiction isn't just about substances.
Not anymore, no. And a key point here is that substance use effects can sometimes look like symptoms of other mental disorders, which can make diagnosis tricky.
I can imagine. Someone using stimulants might seem manic, for example.
Exactly. Then we have the personality disorders.
Okay, personality. How is that a disorder?
These involve long-term, inflexible patterns of thinking, feeling, and behaving that are pretty different from cultural expectations and cause distress or problems in functioning. They usually start by adolescence or early adulthood.
And they're grouped somehow.
Yeah, often into 3 clusters. Cluster A is kind of the audicentric group paranoid schizoid. Cluster B is the dramatis emotional erratic group antisocial borderline narcissistic histrionic. And cluster C is the anxious fearful group avoidant dependent obsessive compulsive personality disorder.
That cluster system helped sort them out a bit. Wow, we're really covering the map here. Any other major groups?
Just a few more key ones. Disruptive, impulse control, and conduct disorders. These involve problems with self-control, leading to behaviors that violate others' rights or clash with norms. Think conduct disorder in kids, or intermittent explosive disorder.
Okay.
Elimination disorders, issues with inappropriate urination or defecation, like bedwetting past a certain age. Dissociative disorders involve disruptions in identity, memory, or consciousness, like dissociative identity disorder, formerly multiple personality disorder, or dissociative amnesia.
Right.
Sexual dysfunctions cover problems with sexual response or pleasure. Gender dysphoria is about the distress someone might feel when their gender identity doesn't match the gender assigned at birth. Crucially, the distress is the disorder here, not the identity itself.
Very important distinction.
Absolutely. Paraphilic disorders involve sexual arousal to atypical stimuli that causes distress or harm. And finally, there are catch-all categories like other specified or unspecified mental disorders for cases that don't quite fit neatly elsewhere but still cause significant issues.
Ooh, that
Yeah.
is incredibly comprehensive. It really shows the sheer range of human psychological experience and where it can become problematic.
It really does.
You mentioned personality disorders earlier and how they're clustered. Our NOVA module source goes into those in a bit more detail, right? Let's maybe circle back to that.
Yes, definitely. The NOBA module starts by defining personality itself, our usual ways of thinking, feeling, behaving, relating. Personality disorders then are when these ingrained patterns become rigid and maladaptive, causing significant problems, like the DSM says.
And it lists the 10 specific ones I mentioned: antisocial, borderline, avoidant, etc.
Correct. But interestingly, the module points out that clinicians actually use the other specified or unspecified personality disorder diagnoses quite often.
What does that suggest?
It kind of suggests that maybe the 10 specific types don't fully capture everyone who has significant personality pathology. It's like a recognition that some people have serious issues that don't fit perfectly into those boxes.
So the system acknowledges its own limits, in a way.
You could say that. The module also talks about personality disorders as syndromes, constellations of maladaptive traits.
Okay, like recipes of traits.
Sort of, like avoidant personality disorder is seen as combining really high introversion with high neuroticism, anxiety, insecurity. Dependent personality disorder involves high neuroticism plus maladaptive agreeableness, like submissiveness, needing reassurance. Antisocial is often antagonism plus low conscientiousness.
So it's about understanding the underlying personality dimensions that have gone awry.
Exactly. And it's often complex. Someone might fit the main traits for one disorder, but also have significant traits from others. The NOBA module also mentions this alternative idea, which is actually in an appendix of the DSM-5.
Oh, what's that?
It's the idea of viewing personality disorders maybe not as distinct categories, but as extreme maladaptive versions of normal personality traits, like narcissistic personality disorder as an extreme form of antagonism, and maybe low agreeableness.
Ah, so a dimensional view versus categorical. Is one view winning out?
It's an ongoing debate, really, especially when it comes to understanding problems with self-identity and relationships, which are core to personality disorders. The current DSM mainly uses categories, but the dimensional idea is definitely influential.
Interesting. What about the evidence behind these 10 categories? Are they all equally well supported?
Not really, according to the NOBA module. The research backing is stronger for some than others. Borderline, antisocial, and schizotypal personality disorders seem to have the most robust empirical support.
And the others?
Well, the support is considered weaker for some, like histrionic, schizoid, paranoid, and dependent. In fact, there were proposals during the DSM-5 revision process to actually remove those from the main list because of the less convincing evidence base.
Wow, so the list itself could have looked quite different.
It could have. It just shows that these classifications aren't fixed forever. They change based on research.
So what causes these? Is it nature or nurture?
Like most things in psychology, it seems to be both. The understanding is that it's a complex interaction. There might be some underlying neurobiological vulnerability, maybe genetic factors influencing temperament or emotional regulation.
Okay, the nature part.
Right. And then environmental experiences play a huge role, nurture. For instance, antisocial personality might involve genetic predispositions interacting with, say, a really harsh or inconsistent upbringing. Borderline personality might involve a biological sensitivity to emotions combined with an invalidating family environment where feelings are dismissed or punished.
That nature-nurture interaction again. Makes sense. These sound like really deeply ingrained patterns. Are they treatable?
Treatment can be challenging, yeah. The NOBA module highlights a key issue. Personality disorders are often egosyntonic.
Egosyntonic, meaning
Meaning the person's way of thinking and behaving feels normal and right to them, even if it causes problems for others or eventually for themselves. They might not see their personality itself as the problem.
so they might not seek treatment specifically for the personality disorder.
Often not. Exceptions might be borderline and avoidant personality disorders because the high neuroticism, the emotional pain, the anxiety can be a strong motivator to seek help. But often, people with personality disorders come into therapy for other reasons: depression, anxiety, relationship problems.
And the underlying personality issues complicate that therapy.
Exactly. The therapist has to navigate those ingrained patterns. But that doesn't mean treatment is impossible. There are effective, manualized treatments, especially for borderline personality disorder.
Like what?
Dialectical behavior therapy, or DBT, is probably the most well-known and effective. Mentalization-based treatment, MBT, is another. These therapies specifically target the core issues of BPD, like emotional dysregulation and relationship difficulties.
That's encouraging. What about the other personality disorders?
It's tougher. The NOVA module notes that the overlap between disorders people meeting criteria for more than one and the wide variation within each disorder makes it hard to develop and test specific treatments for all of them. It's still a really active area of research and clinical work.
Okay, definitely a complex area.
Yeah.
Let's shift gears a bit now and look at therapy more broadly. Crash Course gave an overview of 4 main schools of psychotherapy, right?
That's right. Psychodynamic, existential humanistic, behavioral, and cognitive. Kind of the 4 big families of talk therapy.
Let's start with psychodynamic. That's the Freudian stuff. The couch, the unconscious.
Pretty much the origin, yes. Psychodynamic therapy evolved from Freud's psychoanalysis. The core idea is that our present problems are often rooted in unconscious conflicts, desires, and past experiences, especially early childhood relationships.
And the therapy aims to bring that unconscious stuff to light.
Exactly. Techniques like free association, just saying whatever comes to mind, dream analysis, and the therapist interpreting resistance ways the client unconsciously avoids difficult topics are used to gain insight.
Sounds deep. Is it common today?
Classic intensive psychoanalysis, maybe 4 or 5 times a week, is pretty rare now. It's time-consuming, expensive, and critics argue it's hard to scientifically prove the interpretations. But psychodynamic therapy, the broader approach, is still definitely practiced.
How is it different?
It might be less frequent, maybe face-to-face instead of using the couch, but it still focuses on insight, unconscious processes, and how past relationships shape the present. It's just often more flexible.
Okay. What about the second one, existential humanistic? Sounds warmer, maybe.
It often has that feel, yes. The school emphasizes conscious awareness, free will, finding meaning, and personal growth. Think Carl Rogers, Viktor Frankl.
Carl Rogers, client-centered therapy, right?
That's him. His approach is all about the therapeutic relationship. The therapist provides empathy, genuineness, unconditional positive regard, basically, acceptance, and really listens actively. The idea is to create a safe space for the client to explore themselves and move towards their potential, towards self-actualization.
So less digging into the past, more focusing on the present and future growth.
Generally, yes. Existential therapy, which is part of this school, also tackles those big life questions, meaning death, freedom, isolation. Helping people face those anxieties and live more authentically, the focus is really on empowering the person.
Seems like a very different feel from psychodynamic.
Yeah.
Okay, third school, behavioral therapy. This one sounds more practical, action-oriented.
It definitely is. Behavioral therapy is all about changing maladaptive behaviors using principles of learning classical and operant conditioning.
So the idea is that problem behaviors are learned and can be unlearned.
Precisely. If you change the behavior, the thoughts and feelings often follow. Techniques include things like exposure therapy for phobias.
Like gradually facing the feared thing.
Exactly. Systematic desensitization is a classic example. Or using reinforcement to encourage desired behaviors. It's very effective for specific problems like phobias or OCD rituals.
Makes sense, targeting the behavior directly.
Yeah.
And the fourth school, cognitive therapy.
This one focuses on thoughts. Pioneered by Aaron Beck, cognitive therapy operates on the principle that our thoughts drive our feelings and behaviors. So if you have distorted or negative thought patterns, that leads to distress.
Like I'm worthless or everything always goes wrong.
Exactly, those kinds of thoughts. The therapy helps people identify these automatic negative thoughts, examine the evidence for and against them, and restructure them into more realistic and helpful ways of thinking. Often using Socratic questioning the therapist, guiding the client to question their own assumptions.
So change the thoughts, change the feelings.
That's the core idea. And because thoughts and behaviors are so linked, these two approaches are very often combined.
CBT, cognitive behavioral therapy. I've heard a lot about that one.
Yes, CBT is incredibly widely used and has strong evidence for effectiveness across many disorders, like depression and anxiety. Crash Course also mentions that things like group therapy and family therapy can happen within any of these theoretical frameworks too.
Which brings us nicely to that NCBI chapter on substance abuse treatment and family therapy. It sounds like these two fields haven't always seen eye to eye.
That's a really interesting point the chapter makes. Historically, yes, they've often operated from different perspectives. Substance abuse treatment has typically focused intensely on the individual and the addiction itself, the biological aspects, managing cravings, preventing relapse.
focused on stopping the substance use as the primary goal.
Right. Whereas family therapy comes from a systems perspective. It sees the substance abuse not just as an individual problem, but often as a symptom or part of a larger pattern of dysfunction within the family system.
So family therapy looks at how the relationships, the communication, the family roles might be contributing to or maintaining the substance use.
Exactly. The goal there is often broader, improving family communication, changing unhealthy interaction patterns, strengthening the whole family unit. The substance use might be the presenting problem, but the focus is on the system.
It sounds like they could potentially complement each other really well, though.
They definitely can, and the chapter argues for more integration. But it highlights some differences in typical practice. For example, how resistance is viewed.
Resistance. Like the client not wanting to change.
Sometimes, but the chapter makes a good point. Resistance isn't always just unwillingness. Sometimes it's an inability to do what's being asked, maybe because they lack skills or support. Understanding the person's stage of change, are they even contemplating change yet, is key to minimizing that resistance.
That's a more compassionate view. How do they differ in involving families?
Substance abuse programs might do psychoeducation for families, teaching them about addiction, or maybe multi-family groups for shared support. Sometimes more confrontational interventions to get the person into treatment. Family therapy is usually more about ongoing sessions with the family, working directly on their interaction patterns.
And spirituality.
More emphasis typically in substance abuse treatment, often because of the influence of 12-step programs like AA or NA. Family therapy models haven't traditionally focused on it as much, though that's changing somewhat.
What about the actual sessions?
Substance abuse treatment might be more content-focused, maybe following a specific curriculum. Family therapy tends to be more process-focused, looking at how the family members interact during the session itself.
And the target. Abstinence versus broader relational health.
Right. And even who the client is, the individual in substance abuse treatment versus the whole family in family therapy. Assessment differs too. Substance abuse assessment looks closely at use history, medical issues, etc. Family therapy often uses tools like genograms.
Yanograms, what are those?
They're like detailed family trees, mapping relationships, major events, and patterns, including substance use across maybe 3 generations. Really helpful for seeing intergenerational patterns.
Fascinating. So despite the differences, are there techniques that bridge the gap?
Yes, definitely. Motivational interviewing is crucial for both, and the chapter lists several family therapy models adapted for substance abuse, like behavioral contracting, multi-systemic therapy, MST, which is very intensive, structural family therapy.
Structural, like looking at family hierarchies and boundaries.
Exactly, addressing power imbalances, enmeshment, things like that. Techniques might involve reframing the problem or even temporarily changing who comes to sessions to shift the dynamics.
So family therapists need to understand addiction, and substance abuse counselors can benefit from systems thinking.
That's the core message. Family therapists need to know about the disease model, 12-step ideas, signs of abuse, kids' needs, and critically address the substance use directly. Substance abuse counselors benefit from understanding systems theory, how families react to recovery, sometimes negatively, and concepts like triangles, where 2 people pull in a third to deflect tension.
Triangles. Like a parent and child ganging up on the other parent.
Or maybe focusing intensely on the person with the addiction to avoid dealing with marital problems. It diverts the focus.
Okay. The chapter also mentioned medication in different treatment settings.
Yes. Adjunctive pharmacotherapy meds to help with withdrawal, cravings, or co-occurring mental health issues, and the different levels of care. Detox, which isn't treatment itself, just stabilization, short-term residential, longer-term therapeutic communities, and various outpatient programs, including methadone maintenance for opioid addiction.
And the key is often combining these.
Absolutely. Medication works best with therapy. Outpatient is most common, and family therapy can be integrated there. The push is really for collaboration between the fields, tailoring the approach to the individual's and family's stage of change and phase of recovery.
It makes so much sense to treat the whole picture, the person and their environment. Okay, as we kind of wrap up this exploration, let's revisit something. Crash Course brought up the evolving nature of diagnosis itself. The DSM is useful, but not perfect, right?
Exactly. Crash Course highlighted that tension. The DSM gives us a common language, essential for research, for clinicians communicating, but it's not without flaws. Concerns about potential overdiagnosis turning normal human struggles into pathology. Misdiagnosis is also a risk. And the impact of getting a label. That can be huge, affecting how people see themselves and how others see them.
You mentioned the Rosenhan experiment earlier.
Right, the On Being Sane in Insane Places study. Researchers faked hearing voices, got admitted to hospitals, then acted normally, but their normal behaviors were interpreted as symptoms of their supposed illness. It really showed how powerful labels can be.
A chilling reminder.
And Crash Course stressed that the DSM is a work in progress. It changes. Homosexuality used to be in there. It was removed. Criteria for PTSD have changed.
Yeah.
How we think about childhood bipolar disorder has evolved. New potential disorders get considered, like gambling or internet gaming disorder.
So it reflects our changing understanding and maybe even societal values.
To some extent, yes. It raises big questions. Where is the line between normal variation and disorder? What are the real risks and benefits of putting these labels on people? There aren't easy answers. The DSM is a tool, a very influential one, but we have to use it critically and be aware of its limitations.
Okay, so let's try and summarize the main takeaways from this deep dive. We started with defining psychological disorders not just deviant, but also causing distress and dysfunction, all within a cultural context. We saw the shift towards a biopsychosocial understanding.
Right. Then we explored the DSM-5's classification system, getting a sense of the major categories, from neurodevelopmental to personality disorders. We saw it's detailed, but also evolving.
We then looked deeper into personality disorders, their trait-based nature, the challenges in treatment due to their egosyntonic quality sometimes, but also effective therapies like DBT for BPD.
Then we surveyed the major schools of psychotherapy: psychodynamic, humanistic, behavioral, cognitive, and the integration in CBT, each offering a different lens and set of tools.
And finally, we dug into the specifics of substance abuse treatment and family therapy, highlighting their different starting points, but the real value in integrating them, looking at the individual within their system. And we ended on that note about diagnosis itself being a dynamic process.
Exactly. Which leads us to maybe a final thought for you, the listener, to ponder. Given everything we've discussed about distress being subjective and deviance being so culturally dependent, how do you think our understanding and definitions of mental health might continue to change in the future?
Yeah, what might be considered a disorder 50 years from now that isn't today, or vice versa? And what does that mean for individuals, for society, how we allocate resources?
It really gets you thinking about how fluid these concepts can be and the ongoing dialogue around mental well-being.
Definitely food for thought. So if any part of this discussion sparked your interest of maybe a specific disorder category or CBT or family systems thinking or the whole debate around diagnosis, we really encourage you to explore further. There's so much more to learn.
Absolutely. Keep digging.
Thanks for joining us for this deep dive.